It's now time to start again. Please take your seat. We'll start the second part of this session by a presentation by Teija Kaisa Aholaa. She's a registered nurse, PhD, and she works at the University of Applied Science in Vantaa, near to Helsinki, Finland, isn't it? She recently published an article on reasoning for adherence to aseptic practices in the operating room, and she will be presenting aseptic recommendation for circulating operating room nurse. Thank you.
Thank you. It's an honor to be here this afternoon, and I would like to share my slides if I get them. Okay. Okay, my name is Teija Kaisa Aholaa, and I come from Finland, and that's why it's very difficult to pronounce my name. But I'm used to it. So, I'm a teacher. I'm a principal lecturer teaching nurses since more than 20 years. And researching aseptic practice is my hobby, lifetime. And the objectives for this presentation are to inspect and discuss development of recommendations for AP in operating theaters for circulating nurses, supervising and maintaining infection prevention during invasive procedures. And I'm going to focus on a creation of local recommendations, so my abstraction level is more precise than those WHO recommendations, and the challenges are at least the same. And I started quite early, co-create these recommendations during continuous infection prevention development work as a teacher. We started a dual education for nurses in the early 90s in Finland. So there were universities for scientists and universities of applied sciences for practitioners. And it was a huge challenge to find evidence for clinical practice. And now, for this we are hands-on aseptic practice. And I was lucky to have a hospital nearby to cooperate with me. And here you can see the history. After black box, it's useful to go back to history and show you those steps we have taken. The first observational study I completed was 95-96, and we were focusing on aseptic techniques during general surgical operations in two local hospitals of Helsinki University area. And we measured the agreement of nurses and physicians in those hospitals, in those general operating wards, first in 2000, before our intervention, and then soon after we have documented and co-created the local recommendations for aseptic practices in 2001. And then after that, I videotaped 31 breast operations. We choose breast operations as our target operation because there were, from nursing point of view, certain challenges. And after that, I was reviewing totally 1,042 best operated patients, all documents related to operations. And we have published an article of that, but there was no mention about aseptic practices. So we had to change the focus of the article to report the infections in post-operative infections in breast operations. And then a follow-up survey was completed in 2013. We all know here that the purpose of intraoperative aseptic practice is to control airborne, blood and bloody fluid-borne contact, vector-associated contamination of the surgical patient, personnel and environment during invasive operations. And this is quite a huge challenge. So we soon recognized that we need some kind of a conceptual structure to focus on. We first created 6 sub-concepts what AP could be inside operating rooms. And during this process, we recognized 3 phases: establishment of the sterile field, maintenance of the sterile field, and the last one, disestablishment of the sterile field. Did not have any recommendations in those American Association of Registered Operating Room Nurses in 90s and early 2000. And also we have to focus on certain groups of nurses. In this presentation, I am focusing only those recommendations we have created for circulating nurse. So those recommendations created for instrument nurse, in a scrubbed nurse, they never published. And participation of the personnel for those surveys is also challenging. In 2000, there were 48% of potential respondents fulfilling the surveys. Most of them were nurses. And as you see, the trend is decreasing. So in 2001, there were less, and in 2013, the survey was sent for nurses only, and only 31% responded. So those online surveys, they don't interest nurses, they don't have time, or they are not sure what to do, how to respond. Because it is really lacking the hands-on recommendations. We all know that we spent quite a lot of money for aseptic practices, for sterile equipment and items, but there are variations in clinical practice how we manage with those sterile items. So next we are focusing on screening a little bit how this evolution of the AP recommendations for circulating nurses took place. And this establishment of sterile field, this is not focusing on patient care, like here in our model. There is aseptic technique, aseptic behavior, preparation and protection of the patient for the surgery, preparation of the personnel practicing in the sterile field, central services of the equipment used during the surgery, and environmental services. So we are mainly focusing on those aseptic technique, aseptic behavior, and one item is focusing on environmental services, the blood spills. So we have here a subscale. We have 10 items, and I hope you can get an image what we are recommending. And those lacking items in 2000 and 2001 are telling us how the recommendations have developed and what improvement there has been. We had a 4-point scale, and the overall mean values at this scale in 2013, they are quite high, not big exceptions, but still there is no total agreement according to those recommendations. They are very precise, and the basis of these recommendations is laid on those Association of Perioperative Nurses, AOR, and 2013 updated recommendation in states. And nowadays they have more evidence than they did have in 90s or mid-2000 and early 2000. And inspecting indicators, it is a very common practical measure the nurses do. But this item did not reach the scale. When we are measuring them by statistical tools, we lose some important practices from the scales, like you see. There was 120 statements altogether in this survey, and it may be that the survey was too big, too challenging to answer, so we did not get proper response rates in this latest one. So I have to focus more in the future on focused groups of nurses and focused phases of operation and so. But you can see there are some. We have improved, for example, here, not using sterile item after expiration date. So the trend is increasing, and also the standard deviation is getting narrower, which tells us that the agreement is more coherent. So everyday recommendations we have here to take indicator gloves. This is a new recommendation, like these fluids and medicines decanted near use. They used to open and create sterile fields. There were a holding program in that hospital, so they prepared those sterile fields in good time, and it was not recommended. So they do not agree this 3.23 is the sterile field created less than 1 hour before operation. So it even decreased, but it is because of those clinical changes. We are dealing with time and money, and it's visible also here. And the next subscale is maintenance of the sterile field. Here we have more, we can more follow the evolution of those recommendations. There's one challenge, the presence of circulating nurse staying in operating room during the operation. We can see here that in the beginning of this program, it was 1.66, the mean value at 4-point scale. They did not agree that the circulating nurses have to be present in the operating room and supervise the aseptic practice. And it was very visible in those videotapings and observation even in mid-90s that it should be so that this should be inspected and give the feedback and prepare the brakes and replace the brakes. This scale has quite moderate, like the first scale, the reliability, confidence value, alpha values were not so very high, but the mean values were high. But we can explain that those respondent rates were not so good. But there are clinical challenges. And this, the last subscale, disestablishment of the sterile field, became visible during those videotapings also, because the nurses started to disestablish the sterile field even during the surgery versus during the wound. They were taking some of the suction tubes, disconnected suction tubes and so. But we managed to find, to get only 3 items to this scale when we followed these technical advices of scale construction. Gloves used during this establishment of the sterile field, it has a very high mean value, and also the standard deviation is quite narrow, so they accept it. Bloody gloves not removed outside operating room, high value and narrow standard deviation, not disestablishing sterile field during wound closure. It is a little bit lower, but we are improving, and this mean value is quite high, but due to rate of number of respondents, the alpha value was not good. But this is not statistics. This is hands-on practice in operating theater. And we have here 20-point scale with a total mean value of 3.44, and the Cronbach alpha value for this total scale was 7.82, and it's acceptable. But still we are discussing about those evidence issues. We did not accept in those clinical interventions, those recommendations which did not have any scientific background. And we were discussing many times in AOR and conferences about these. And it's a huge work to create evidence for such issues in clinical practice, but it is possible to do in a close cooperation with students, for example. In Laurea, we have a model, learning by developing model, in which we go to the operating rooms. They give us problems, and we are solving the problems. In these hospitals, we start with our students issues like that, how to don a sterile robe. And we create for very focused issue recommendations. But the circulating nurses practice is quite challenging because it demands experience, it demands decisions to make. So nursing students are not the first ones to do it, so we need the clinical connection. But we have more recommendations. Only 20 of those 120 items was accepted for the scale according to the scientific procedure. We have, for all those 3 phases, more recommendations presented in listers in late 90s, and they still exist there. But for those recommendations, we have evidence according to the particle counts, air currents, and such of issues, but we have to collect it. For example, this maintenance of the sterile field, unscrubbed person keep 50 centimeter distance to the sterile field. We know the droplets, but we have to collect and reason what is the reasoning here, what level of evidence we have, how we are going to position those powered instruments and so to reach these. But the circulating nurse's task is to supervise and to establish, maintain, and disestablish the sterile field. So it's a holistic view. Why do we this? We completed a study during this procedure, which was published in Journal of Clinical Nursing, and there were variation in aseptic practice, but there were also a huge stress. And according to those stimulated recall interventions, there were 1,306 pages, Arial 11, space 1 data, which gave these results. The narratives of the nurses expressed stress from desire to fear. And the stressors were time, power, moral, working moral, experience, equipment, patient, when they did their decisions, whether to follow those recommendations or not. You can read the paper, it is very interesting. And we have challenges to tackle in the AP development. We have to earn the trust, like we heard in Black Box, but the nurses trusted me because I was working in the operating room with my students, and they all looked at the videos and they learned. We have to find the evidence for reasoning to AP. We have to facilitate the recommendation adherence of the personnel by helping them with students and cooperation. We bring the research, they validate it locally and choose the most critical one. Difficulties in publishing the local results I'm very familiar with. My research groups are small, and paper after paper responds me that this is not on the focus of our paper, because this is local and you need more explanatory power. And ethical limitations, we are not able to skip out those aseptic practices we have completed years, but we need badly cut the costs. So we need to consider what are the most important. And we have discussed about the laminar currents, air currents, and so, but it is not the issue. The issue is what shall we do under the airflow? How shall we put our hands on the aseptic practice? Why? And according to what evidence? Okay, but now this was my presentation, but there are still questions to ask. How shall we continue? It is worth continue and discuss in a more bigger public, in multi-professional consortium perhaps, in transnational consortium perhaps. I have applied money for education from European Union for this, but not been successful. But there are some papers I have published. If you are interested in, please join developing recommendations with me. Merci beaucoup. And this is supervising nurse. And the aseptic practice is a very wide lake, but it is not impossible to handle if you are bright enough and you have recommendations. Thank you.
Thank you very much. The presentation is now open for question. If you have a question on aseptic procedures. I've got one question more, it's more one comment. You said that it was very difficult to publish papers on behaviors, so I fully agree with you. How can we do to improve this, to make people aware about the need for qualitative assessments, and what can we do to change surgeons' point of view around behaviors and the improvement of behavior in operating rooms?
I try to answer your question. We first had surgeons with us. Actually, we had one managing doctor who was anesthesiologist, and we tried to collect those surgeons and all physicians with us to decide and discuss, but it was not impossible. They did not want. But I can see that with these simulation measures we have nowadays, we should do like the black box issue, but perhaps with the easier equipped system, that we could concentrate on the team, because it was visible in our discussions and stimulated recall videotapings that the nurses behave totally different within different teams. They even withdraw from the aseptic recommendations with a certain surgeon, and with certain surgeon they followed them. The team coherence is very important. And I have initially recognized 11 steps how the nurse is going to reach the acceptance of the surgical team. And I'm looking forward to research that more when I'm retired, because I'm a teacher and this is my hobby. Okay, did I answer your question?
Yes, thanks.
Thank you.
Do you plan to do a qualitative assessment with interviews in people, staff in operating rooms about their feeling on aseptic measures? And
it was a stress, and like I introduced here, there were desire, they were hoping that they will follow, but there was also a fear, frustration, tension, and pressure. And it is related not only the experience level of the nurses, but in the team. And there were difficulties to understand the value basis. I count very much on the theory of action of Jori Henrik from Richt in Finnish philosophy. The value basis, we have to share the same. And I'm positive we do have, but we have to make it visible that we discuss about these issues. What is the time? What is the moral? What is the experience? And we have to ask those questions. Why are we doing? How we are reasoning those issues? So we share the mutual situation there within this sterile field. So plenty to do. But there is a bright bird.
Any questions in the audience?
I have a question.
Thank you.
Thank you. Sorry, I have a quick question. Something just looking at the slide around stress and pressure within the team. The WHO's surgical site checklist includes the team members introducing themselves and the role that they will undertake during the procedure to help the team understand how they should work, even though many of them know each other anyway. But do you think if adopted and used well, the surgical site checklist might help reduce some of the tensions within the team?
There are some research concerning the intraoperative phase, but like we heard in a black box presentation, the surgeon is so focused on the surgery. And the feedback from aseptic practice in Finland, it's mainly on nursing. The surgeons trust on nurses, but there is a barrier how the nurse is able to interrupt the surgeon's work And if the nurse is very novice, there is no courage enough to interrupt and correct. So the checklists are good, but I have reviewed all those checklists of WHO recently, and they are focusing only in little bites of the aseptic practice hands-on. So we introduce in Finland all, and we know with who we are operating, and we plan the operation well, but still the situation hands-on, it's so demanding. It is situation-specific and context-specific, so it changes. The temper of the surgeon is one important issue, how the nurses dare to interrupt from the aseptic practice point of view. And they sometimes think that they have to document it. And they tried, after this documentation, they documented more, and it is for their safety that they have told the surgeon that there are breaks, but the antibiotics may cover. It is very difficult to screen. I tried to do this pre- and post-intervention survey among breast operations, the amount of those surgical site infections, and there was no statistically significant improvement. Actually, the rate was increasing because I don't know what reason, perhaps they documented it more carefully or what, but it is really challenging to show the improvement with aseptic practices. But we are in an era where the antibiotics doesn't help. We have to go back to those conventional measures. But what measures? They have to be recent, they have to be evidence-based.
Thank you very much.
Thank you.
Thank you.